As you're likely very aware, Dato-DXd, which is a TROP2-directed antibody-drug conjugate, is now approved for patients with locally recurrent or metastatic breast cancer or locally advanced or metastatic EGFR mutant non-small cell lung cancer. And so you are likely using this drug in your patients on a daily basis. As a result, there are a number of key adverse events that I think it is important to be aware of in terms of how to prophylax your patients as well as manage them on therapy. Today, I'm going to highlight two recent publications in The Oncologist, which were published in 2025. I was the lead author on one of the publications. The other was led by my colleague, Dr. Merrick Bernstrom. And I would like to highlight that both publications provide a discussion and some nice display items regarding the key AEs for your patients receiving Dato-DXd. So with respect to ocular toxicity, at baseline, it's very important to get either an ophthalmologist or an optometrist to evaluate your patient. You should also provide your patient with preservative-free artificial tears that they can use prophylactically 4 times a day. While on therapy, it's important to monitor for ocular toxicity, typically in the form of increased tearing or dry eyes. If that toxicity is increasing and not responding to preservative-free artificial tears, involving your ophthalmology professional as soon as possible is critical to continue to monitor and evaluate. If those toxicities increase, dose delay or dose hold can be very effective at managing this toxicity and allowing patients to stay on therapy. For stomatitis or oral mucositis, it's important at baseline to ensure good oral hygiene using a soft toothbrush, avoiding potentially spicy or crunchy foods, providing your patients with 2 prophylactic mouthwashes, a symptomatic mouthwash, as well as a steroid-containing mouthwash that they can begin using at the initiation of therapy. Again, while on therapy, if toxicity does occur, it's important to assure adherence to these mouthwashes. And if toxicity increases to grade 2 or 3, as discussed at much greater length in the oncologist publications, dose delay and dose hold can be very effective at mitigating and managing these toxicities to allow your patients to stay on therapy for potentially many years, as we have seen on clinical trial. Final toxicity is interstitial lung disease. This is an important toxicity to watch for. At baseline, it's important to evaluate for any prior history of interstitial lung disease or pneumonitis, which can be an increased risk while on therapy. While on therapy, if a patient develops any symptoms consistent with interstitial lung disease, such as dry cough, increased work of breathing, it's important to immediately hold the therapy and refer your patient to a pulmonologist for further evaluation. If interstitial lung disease is diagnosed, immediate interventions with immunosuppressive agents, specifically steroids, and monitoring for resolution of the toxicity. If the event was grade 1 and resolves, it is reasonable to re-challenge, in which case we have a lot of experience with a lack of recurrence of the toxicity, but certainly if it's grade 2 or higher, termination of the therapy is appropriate. If you're interested in learning more about these toxicities and optimal management, you can download both papers on the infographic that accompanies this video. And I thank you again for your attention today.